he comes every month, every 2 months, it will be an easy for them. But for all people, like I have good number of patients that are in observation with low volume disease.
Excellent. If I may share my experience with you, with all of you, in my experience in patients with favorable risk, low volume disease with sunitinib, even modified dose of sunitinib works very well. As a matter of fact, the only 3 patients I have in my practice who had CR to first-line treatment was with sunitinib. Some of them were on 25 milligrams dose, like CR. They typically get CR after 6 to 8 months of treatment. But again, there is some selection bias. Those patients whom I start sunitinib on are typically patients with low volume disease, favorable risk. So there may be an element of selection bias here. So I just want to share this with you, and because I still think that sunitinib works in favorable risk, especially that all the TKI immunotherapy trials that looked at this combination versus sunitinib in favorable risk disease did not show any overall survival benefit to my knowledge, including 9ER with cabo nivolumab. Does anyone have any questions, any comments? تفضل أحمد.
Yeah, thank you, Dr. Nidal. Thank you, Dr. Ashwag. That was an excellent case. It's just outstanding presentation, basically, and the responses and how you dealt with the case was absolutely top-notch. I think it's going to be more of a general question to all oncologists. What's your approach to metastatic RCC, the ones who would have the favorable prognosis or prognostic index versus the high risk, basically, RCCs? Is there any difference in terms of what would you choose in terms of immunotherapy or TKI for each group?
Well, Ahmed, the data is clear. Like, if you ask me my favorite option, I will use TKI and IO, regardless to the risk group. And even I don't look at that. Patient with high volume disease, symptomatic, I'll start based on amount toxicity profile, weight, benefit, risk. Then I'll start and explain to the patient. So I don't give like, but Nidal, what he mentioned about low volume disease, good prognosis, هذول patient, yes, we might go with single agent TKI. It works very well, and حتى with a lot of modification. And I give Sutent 1 day on, 1 day off, and continuous, even without having this 2 weeks off.
Absolutely.
It works well. So I think for me, I prefer IO-TKI regardless to the risk group.
Any preferable kind of like combination of TKI IO?
And I prefer the 2 combination, lenvatinib pembro, cabo nivo. Honestly, these 2 combination, I think it changed the whole treatment for RCC in general. Yes.
I would agree with Ashwag 100%, Ahmed. As I said, axitinib pembrolizumab is not funded. Sometimes you can get away with it. I find pembro plus axitinib 5 milligram BID to be more tolerable than lenvatinib 20 pembrolizumab. We end up doing a lot of dose modification to lenvatinib. We go down to 10, 14 milligrams. So this is my observation. But with Ashwag is definitely has encouraged me to use cabo nivo, and we may file a request for that at some point. ما شاء الله تبارك الله.
ونقدم الحالة المرة الجاية يا
شوفي والله يعني مبسوط والله أنا بصراحة إني شفت ريسبونس زي كذا. إن شاء الله يعني استمر عليها بإذن الله تعالى.
Dr. Nidal, Dr. Ashwag, there's a question from Dr. Nadia BB, I think, and she's asking what are the serious side effects of cabo nivo therapy?
Most common side effect that I see, like for immunotherapy, all the side effect is modest and sometimes doesn't happen. The most common side effect is the GI toxicity. Patient will come with GI upset, diarrhea, not eating. Sometimes mucositis will be severe. But the tolerances varies from patient to patient. I think GI toxicity is the commonest that what I see. I didn't see any like skin toxicity, honestly, with this component.
I agree, especially with the 60 milligram dose used as a single agent. It causes a lot of toxicity. Alhamdulillah, the trial used for 40 milligrams instead of 60. And we end up
كالعادة هنغير كل الدوزز. أنا والله اللمباتنب I use 14 مع
14 كويس.
exactly yeah we modified a lot.
SubhanAllah, tolerance of lenvatinib in RCC patients is totally different than HCC patients. And my HCC patients, they barely tolerate 8 milligrams. يعني regardless of the weight. تجيني واحد يعني heavy weight where we should probably give them the full dose of 12. They really don't tolerate it. I have a few also on 4 milligrams.
And I have a lot
Oh,
of
wow. Wow.
yes, the HCC is not tolerated like RCC. And I see the extreme, honestly, between these patients. Right? Like
Very interesting. MashaAllah, tabarakallah.
Excellent. Should we, if no one has any additions, should we move on to case number 2?
Yeah.
Absolutely. Yeah.
Absolutely. Well, I'd like to thank Dr. Ashwag for the excellent presentation. I'd like to thank Dr. Nidal as well for his moderation of the first session. So now it gives me pleasure to introduce Dr. Kanaan Al-Shamari, who is a national expert in sarcoma subtype of oncology, and he's also an expert in GI oncology. He's a medical oncology consultant at the National Guard Hospital in Riyadh, and he's also an assistant professor at the King Saud bin Abdulaziz University. He's the director of MENA NCCN Regional Coordinator Center, and he also the program director of Medical Oncology Fellowship Training Program in National Guard Hospital. Dr. Kanaan is going to walk us through a challenging case. This time is going to be about gastric cancer. So Dr. Kanaan, the floor is all yours.
Thank you very much, Dr. Ahmed, for the humbling introduction. Happy to be here with you, of course, Dr. Ashwag and Dr. Nidal, and our dear guests. So I chose a challenging case. This is one of my first cases that I've treated with gastric cancer since my arrival from Canada. She's a 69-year-old woman who was referred to my clinic from the southern region with an already made diagnosis of metastatic gastric cancer. The diagnosis was made through an EGD and a biopsy showing adenocarcinoma, and the referral letter said that she had liver or a liver metastatic deposit, and hence we accepted her in National Guard and she came to my clinic. Upon her arrival, her performance status was actually excellent at 1. She was hypertensive and had a remote history of a prior appendectomy. She was only taking amlodipine 10 milligrams daily. She did not have any drug allergies. She came from a relatively poor socioeconomic status. She was married to an elderly gentleman and she had no kids. And she was actually the carer of her elderly husband. Now, this is her initial image. So this is a CT scan of her at her initial presentation, and this was around June, July of 2020. So as you can see here, there's a large liver metastatic deposit. Now, the radiologist also mentioned that she had thickening in her stomach, and she had peritoneal metastatic disease. Now, we always re-review pathology, and we did that back at the time, and her stomach biopsy came back as gastric adenocarcinoma. As we usually do, we always request molecular testing, and at that time we requested microsatellite instability proteins, and also required requested HER2, and she came back as microsatellite stable, and she was HER2 negative. At that time, in 2020, we did not really, or we were not ordering PD-L1 and CPS scores. So we brought her to our GI tumor board. I wanted to hear the opinion from our surgeon for her liver disease and somewhat limited peritoneal disease. We had and we still do have a very courageous surgeon who informed us that since she has limited peritoneal disease and a single liver lesion, that perhaps if she responded, that perhaps radical surgery could be an option here. And since she was fit, I have decided to start her on FLOT chemotherapy. So we inserted the chemotherapy line. We started her on Q2 weekly FLOT. Her performance status was excellent. Our aim was to downstage her disease so she can reach radical surgery. So I gave her 4 cycles of FLOT. To be honest, her tolerance wasn't really the best. She had 2 admissions with febrile neutropenia. And unfortunately, after the 4 cycles of FLOT, she actually had disease progression. Her performance status deteriorated. She became a 2 to perhaps 3 in terms of performance status. She also developed symptomatic ascites that needed frequent drainage. In terms of second line, I had a clear discussion with her and her very elderly husband, and we decided together to give her palliative second-line single-agent Nivolumab based on the ATTRACTION data. So we'll take a short break now from the case, and I'm going to present to you the ATTRACTION 2 data. So this is a study that basically looked at patients who had unresectable or recurrent or metastatic gastric or gastroesophageal junction cancers, mainly adenocarcinoma, who had prior regimens with at least 2 regimens or were refractory or intolerant to standard therapy and had a good performance status. These patients were randomized 2-to-1 randomization to Nivolumab, 3 milligrams per kilograms every 2 weeks versus placebo, and the primary endpoint was overall survival. Now, this study was basically done in the Far Eastern region, so Japan, Korea, and Taiwan patients. So these are the patient demographics and baseline characteristics. So the majority of these patients were actually gastric cancer patients. A small number of them had GEJ junction adenocarcinoma. And if you have a look at the prior regimens, the majority of patients actually had at least 3 prior regimens. So they probably took 4th-line Nivolumab or thereabouts. Now, in terms of overall survival, in the whole cohort, the difference was quite modest. It was 1 month difference from 4 months to 5 months. Hazard ratio was decent, actually, at 0.62, and the p-value was statistically significant. And if you have a look at the survival curves, with our known sort of information about immunotherapy, you tend to see prolonged or durable responses, and you see flattening of the curve in the end, which is the case here. Now, in terms of subgroup analyses, which patients benefited the most from Nivolumab? To be honest, in summary, the majority of patients actually benefited from the Nivolumab. The farther away or the higher the number of previous regimens, the higher the benefit of Nivolumab being given later on. Patients with prior ramucirumab also benefited from Nivolumab in later lines. In terms of responses and disease control, so the objective response rate was almost 12% in the Nivolumab arm. And if you look at patients who had, flattening of the curve in the end, patients who had excellent responses and survived for 2 years, their objective response rate was as high as 65%. Now, if we start to look at certain subgroups, so I mentioned that 12% of patients actually had objective response rate. So these are the patients that had CRs and partial response. So if we look at their survival, they actually went on and survived an impressive 27 months in terms of median overall survival. So these are the patients that actually responded. Now, if we look at patients with stable disease, they still benefited from Nivolumab. Difference was slightly higher than 1 month, and the hazard ratio was decent at 0.75. Now, patients with progressive disease really did not benefit much from Nivolumab. In terms of progression-free survival, there is later separation of the curves. However, the difference was quite modest, despite being significant. In terms of safety, Nivolumab patients had 40% treatment-related adverse events. The majority of these adverse events were mild, with skin toxicity being the commonest, which is a known toxicity of immunotherapy. Now, treatment-related adverse events of special interest, so ones that are related to Nivolumab, we can see that interstitial lung disease affected almost 2% of cases. Rashes and others were less common. If we look at this special graph that tells us about the time frame and development of treatment-related adverse events, we can see that skin toxicity was the commonest to occur in the first 3 months of therapy, as shown here. If we also look at patients who developed toxicity, we can actually see that they survived also longer and they benefited more from Nivolumab. So these are patients that had thyroiditis or skin toxicity from Nivolumab. Now, this is well known that patients that actually develop some sort of toxicity probably do have a better response and a durable response, as evidenced by this Kaplan-Meier survival curve. So back to our case, we started Q2 weekly Nivolumab. Very minimal toxicity was observed, if any, and hence I spaced out her Nivolumab to be being given every 4 weeks. She tolerated therapy quite well, and after 3 months, a scan was done. Now, if you recall how big the liver metastatic disease was, I can show you here on this scan that it became quite smaller. Now, you can see that she does have some ascites, but it was significantly less compared to previously. Now, this scan happened around March of 2021, and the impression from the radiologist that this patient had an improvement in her liver metastatic disease, ascites, and peritoneal metastases. So I continued more Nivolumab. Her performance status actually improved significantly, and she was no longer symptomatic. She continued to have partial responses on scans being done every 3 cycles. Now, around November of 2021, we performed a PET-CT scan, and she did have, as you can see here, some FDG avidity in the stomach, very limited FDG avidity involving the peritoneal lymph nodes, and strangely, her liver was no longer FDG avid. So I brought her back to our tumor board, and I discussed with our dear surgeon, and he actually agreed to take her for staging laparoscopy. So this occurred, and intraoperatively, he removed some peritoneal nodules, sent them to the pathologist, and the pathologist reported to us that these were pathologically complete responders. Intraoperatively, the surgeon informed me that she had very limited disease. So I took her back to our tumor board, and now what I probably should have mentioned here is post-operatively, she did have a rocky post-operative course, prolonged intubation. She spent some time in the ICU. However, she did recover and went back to being normal. So in the tumor board, after her slightly rocky post-operative course, the discussion with the surgeons is that we should probably continue a bit more Nivolumab. So I did that. After she recovered, she no longer had any ascites. Her performance status improved again to 0. And strangely, she actually lost some follow-up. Now, she came from the south, so probably for 3-4 months, she never came. We were all concerned. However, she did come back after 3 to 4 months of losing follow-up and no Nivolumab being given. I repeated her scans after reintroducing Nivolumab for some time, and in April of this year, her PET-CT showed no evaluable disease. Again, back to tumor board, discussion with the surgeons. We actually looked, and the patient had finished complete 2 years of Nivolumab. She does have no evaluable disease based on the last scan. we all agreed in consensus form to start surveillance. I am planning, inshallah, to see her after Eid to continue surveillance and to review her scans. And by that, I conclude this, at least what I think is an interesting case. And I am happy to answer questions in the discussion and to hear your opinion, Ahmed, and your opinion, Nival, on this case. Thank you.
Well, what can I say? That was an excellent case, perfectly managed from A to Z, and yet such an amazing ending. And inshallah, this ending will continue to last for even longer than now. Congratulations, Dr. Kanaan. That was excellently and well, beautifully handled as well. So I'd like to encourage the audience to type in their questions in the Q&A box. I have a couple of questions for you, Dr. Kanaan. So from the get-go, basically, it was very clear that this patient had a gastric adenocarcinoma to the liver, not basically any just liver metastasis. It was a huge liver metastasis, quite apparent on the CT scans that you had shown, along with significant peritoneal mets, not only limited. And she had been treated with an aim just to try to downstage everything because she's young and try basically to be heroic and what have you. And you have started flat. It is kind of unusual practice to start flat right up front, especially if you're not going to go ahead with a new adjuvant treatment. Do you have any kind of explanation for choosing the flat in that kind of option? Mind you, I actually had used that in a couple of cases as well.
So thank you, Ahmed. Great question. Indeed. To be honest, I think prior to decision of using what sort of therapy, we need to think about what's our goal here. Is it palliative or is it radical? In a palliative setting where the surgeon would not tell me, Kanaan, maybe I can resect this if it shrinks, I'd probably use doublet chemotherapy with FOLFOX or whatever. I wouldn't think about triplet chemotherapy. But we always are, and we're not surgeons. We don't decide for surgeons, Ahmed or Nidal. We always ask our surgical colleagues, especially since she had a single, despite being large, but a single liver lesion in a single lobe. And the surgeon said, Kanaan, if this lady responds, maybe I can resect her and do a peritonectomy plus minus HIPEC, since she had very limited peritoneal metastatic disease to start with. And hence I was guided by this, and I really wanted to go aggressive, and I gave her a FLOT. She did suffer, to be honest, with FLOT. I'm not sure if, her admissions with febrile neutropenia and decompensations were because she was actually progressing or because of toxicity of FLOT, because she did progress, unfortunately, strangely though, on triplet chemotherapy with FLOT.
Yeah, so I was shocked. I was expecting basically to have at least some responses, but yet she actually progressed. So the second question, and I think it's just going to be a natural question to you now, is first of all, how would you approach the use of immunotherapy in gastric or GEJ adenocarcinoma? Would you rely on the PD-L1 CPS with all the confusion that's being around it? Looking at the CheckMate 649, the Keynote 590, and now we have more and more of kind of monoclonal antibodies and immune checkpoint inhibitors mainly to be used nowadays. Would you check for something like an MSI or PD-L1? What would trigger you to use a Nivolumab or pembrolizumab or whatever immune checkpoint inhibitors in terms of metastatic disease for gastric adeno?
So academically, Ahmed, I would definitely ask for PD-L1 CPS score, and probably I should wait for it to come back, and I should let it guide my decision. However, practically, Ahmed, and I'm not sure how long it takes for PD-L1 CPS score to come back in your institution or you, Nival, and maybe Muhammad can also comment, but it really is not a very quick test to come back. And it's not like MSI, where it's IHC, the pathologist would, do the stains and call me back the next day, or just post the report on our system and tell me, is this patient MSI high or not? MSI, I would definitely wait for the results and would like to see it. And it usually comes back quite quickly, as well as HER2. HER2 is a relatively quick test.
Yeah.
So I would let MSI and HER2 guide me initially, probably for patients who are HER2 negative, who do not have a contraindication for immune checkpoint inhibitors. I'd always consider FOLFOX nivolumab in the first-line setting. For patients who are HER2 positive and no contraindication to immune checkpoint inhibitors, I would apply the most recent data of Herceptin, Pembro, and Capox or FOLFOX. And I actually have a case who did very well on this. Now, I know that the study has recently been updated and reported, and they actually reported that progression-free survival was statistically significantly positive. I think overall survival wasn't positive. You can probably correct me, Ahmed,
No,
but I would definitely consider using it. So I'd probably give her FOLFOX Nivo. If my intent was purely palliative, I wouldn't wait for CPS / PD-L1 score.
Last question from my end, but I have to welcome Dr. Mohammed Al-Ghani, who had just joined us. And basically, I wanted to thank you for inviting me and the rest of the group to this webinar of challenging cases. So thank you, Dr. Mohammed. So the last question to you, Dr. Kanaan, what's your take on the new study, the Spotlight, the one that looked at the use of zolbetuximab in gastric adenocarcinoma? Would that change practice, you think? Should we have an urgent and quick access to the tests and to the medication?
Well, Ahmed, we always should think practically. This goes back to your same question about would you wait for CPS PD-L1? Do we have zolbetuximab? No, we don't. How quickly can we get access to it? Well, I'm not entirely sure. Would I totally apply it? Probably not. But again, in an academic setting, probably we should. The data is exciting for sure. I don't think we're going to have access to it quickly anytime soon.
Thank you, Dr. Kanaan. I'm done with my questions. Back to you now, Dr. Nidal, if you have any questions. I'm just going to check the Q&A as well.
MashaAllah, tabarakallah. Do you hear me, guys?
Yes, we can.
Excellent response. This guy, mashallah, ended up doing very well. الحرس ما شاء الله تبارك الله حاجة عظيمة والله ما شاء الله.
Has nothing to do with حرس نضال.
الشباب الحرس ما يحتاج. My question, on the second surgery, when the surgeon opened up her abdomen and found limited disease, was there any CRS done at least, or he just said, no, go ahead and complete?
So I think this surgery was in preparation for CRS and HIPEC. I think he wanted to see, there is staging laparoscopy is a well-known procedure that surgeons typically would do before embarking on very big CRS and HIPEC. So he opened it up. He did see limited peritoneal disease. He removed a few of them to send them to the histopathology. And luckily, the pathologist called me and said, Kanaan, this is all fibrosed, necrosed tissue. This is CR. This was disease that actually disappeared. Luckily. And at that time, post-operatively, there were a few issues. She did spend some time in the ICU post-operatively. The surgeon probably thought, we shouldn't really go heroic again after her issues with prolonged ICU stay. She recovered, alhamdulillah, well. بعدها I reintroduced my Nivolumab, said, let me try and consolidate this response until she lost follow-up. She came from a very poor background. She barely managed, despite the institution's help with these patients of offering them flights and so forth. Sometimes she would come, sometimes she couldn't come due to some social and financial circumstances. Despite all of this, to my pleasant surprise, alhamdulillah, her PET CT earlier this year of 2023 showed no evaluable disease. She was in complete metabolic response, alhamdulillah.
MashaAllah, tabarakallah. Well, Ahmed asked all the smart questions, so we probably would need to move to Dr. Mohammed Al-Ghani, who is again well known to everybody. MashaAllah, tabarakallah. He's the head of the cancer genetics program, and he's a GI, GIST, and I believe cancer genetics expert in National Guard. He's going to present a case of a lower GI malignancy. rectal cancer case. Muhammad, the mic is yours, my friend. And thanks for your kind invitation.
Thank you very much, Nidal and Ahmed, for joining us. It's always a pleasure to have you and to have this interesting discussion with you. And I find it's also difficult to present after Dr. Kanaan. He's always excellent speaker with, mashallah, very excellent outcome. So, sorry I joined late. I have some technical difficulties.
Dr. Muhammad, we cannot hear you.
You are muted, Muhammad.
Yeah, even the camera is blocked off.
طيب تسمعوني الحين؟
Yeah, we can hear you now.
Yeah, you can hear you.
I will try to share my screen.
Okay.
شكلك complete response برضه يا محمد.
اصبر شوية يا نضال. Do you hear the slide? Do you see the slide?
Yes, we can. Yes.
طيب بسم الله. So this is a case of rectal cancer. This is a pleasant 29-year-old male patient. He's previously healthy. He presented to the GI clinic with intermittent rectal bleeding and abdominal pain and weight loss for 7-month duration. So he has these symptoms for sometimes when he starts to lose weight, he starts to think this is something serious. And at that time, he considered the medical attention. He has a family history of colon cancer in his mother and his sister, both diagnosed with colon cancer. Unfortunately, the mother died and he had 35, and his sister, she's on ongoing therapy. So he was seen by the GI team, had colonoscopy that showed partially obstructing mass with friable mucosa. And the mass was found 5 centimeters from the anal verge and extended 10 centimeters, and the biopsy was taken. So the biopsy came back as a necrotic tissue with few malignant cells suggestive of colonic carcinoma. So if you can see in your left side, as you can see, there is a huge mass in the rectum. It's measure 7.5 by 4.5 centimeter, and the pelvis MRI, as you know, it's a standard to get a pelvic MRI for local staging for rectal cancer, confirmed the finding of mid to upper rectum rectal cancer with a clinical staging of T4A/N2 with positive CRM. So from radiology, it's clear that he has a locally advanced disease, and luckily he has no distant metastasis. So what would be the next step in this patient? So he was seen by the colorectal team, and since the patient has partial obstruction based on the colonoscopy finding, he was offered diversion colostomy that was done in June 2022. Then, as what we do usually with most of cancer cases, the patient was brought to the GI tumor board with a final diagnosis and impression of the tumor board that this patient has locally advanced disease and to be considered for total neoadjuvant therapy. So the patient was referred to us in the medical oncology clinic. When I saw him first time, he was not able to sit. He was lying on the bed during the clinical visit due to severe rectal pain. His performance status was 2 due to significant pain. So at that time, we discussed with him the potentially curative intent approach. And since he's young, also we discussed with him sperm banking that was done. And we started him on Xelox. And given his family history, we ordered also genetic testing. So he finished 4 cycles of chemotherapy. After these 4 cycles, we repeated his pelvic MRI, And it actually showed almost the same appearance of the tumor without any sign of response to these 4 cycles. And also the patient was still in pain and not gaining any weight. At that time, we got the result for genetic testing that confirmed that this patient has Lynch syndrome and he has mutation in MLH1. So what would be the next? So a patient who with locally advanced, young patients with locally advanced disease who was planned for TNT, he was offered the chemotherapy, started without any sign of response. And now you get a result that this patient has rectal cancer related to Lynch syndrome. So we are talking about microsatellite unstable tumor. So what would be the next step in his case? So should we move to the chemoradiation treatment, long course chemorad? Should we consider short course of radiation if this is doable and go for surgery? Or should we consider immunotherapy in this patient? So this patient, was discussed in our multidisciplinary team, and we got the consensus about offering this patient immunotherapy. So he was started on Nivo AB for 1 cycle, followed by Nivo for every 2 weeks. So I can say from the first visit when he came in 2 weeks, actually has remarkable clinical response. He has less pain with less use of pain medication. I repeated his cycle 2 months after therapy just to make sure that the patient is responding, and we found that he has a remarkable decrease in the size of the rectal cancer, and the size decreased from 10 centimeter to 5 centimeters. So about 50% reduction in the tumor with 2 months of therapy. So what would be the next? Actually, this is just to compare his image after and before therapy. So when I saw him in the clinic and I saw this response, I decided to go more with immunotherapy with my thought that if I continue more therapy, maybe I will get better response in this patient. So he received another 3 months of treatment. And as you can see, the one on your right side, the 2 image, the one above is the one as a baseline before starting therapy. And as you can see down, the remarkable radiological response that he has, not only in the primary mass, but also for the locoregional lymphadenopathy. So he has also PET scan that demonstrated residual activity in the primary tumor, and there is no distant metastasis. So the case was presented again in the tumor board, and the impression that although he responded nicely to immunotherapy, the PET scan is still showing some activity on the image, and also there is some residual lesion by MRI. So what would be the next step? So any thought, Nidal, Kanaan, or Ahmed, should we go now to the surgical management, or should we consider radiation therapy in this patient before moving to surgery, or should we just continue immunotherapy and consider non-operative approach?
So Muhammad, this is a guy who had CR to immunotherapy prior to surgical intervention?
No, actually, we are not sure that he has complete response. He has residual activity on PET scan. He has still residual mass by MRI.
I would opt for surgery for now.
But the MRI assessment is like still shows locally advanced disease with their lymph node.
No, it's not anymore locally advanced, but there is still a mass in the rectum with some enhancement that is suggestive of residual disease.
I think I would vote for surgery at this point, but doing doing short course radiation followed by surgery is not wrong.
Okay.
Yeah.
So we have this discussion in the tumor board as well, and the surgeon felt more comfortable to offer him short course of radiation before doing the surgery, and we agreed on this. So he was referred to the radiation oncologist, and he offered a short course of radiation. And in 2 weeks after that, he went to have lab that was converted to open total colectomy with low anterior resection and ileostomy cariation. So the decision in this patient, the surgical management of this patient actually was guided by his genetic testing. So given his extensive family history of cancer and already 3 members diagnosed with cancer, and he already developed cancer in his 20s, we decided just to do prophylactic colectomy. It's not a standard to do it in patient with Lynch syndrome. However, in this patient and in this family, it was indicated. The surgeon called me after the surgery, and he told me he thought that the MRI and PET scan might underestimated the residual disease, and he removed a large mass from the rectum, and he thinks he still have significant residual disease. However, the final pathology has the final words. He has no residual cancer. It's all fibrotic and inflammatory tissue with no evidence of active malignancy. As you can see, something that we start to see more and more with those patients who respond to immuno and even for chemo, the non-caseating granulomas. I have seen this in different patients, and it's a sign of response to therapy. So what would be the next in this patient? So we have a patient who is locally advanced disease in the setting of Lynch syndrome without response to chemotherapy. Then he was responded nicely to neoadjuvant immunotherapy plus short course of radiation, and he has completion surgery. So what would be the option on the post-operative settings? Should we observe this patient? Should we continue immunotherapy? Should we offer any chemotherapy, which is, I don't think, the case here. So what do you think, guys?
So if I may,
Yes.
So observation is not wrong. I would personally give him 3 months of immunotherapy at least in adjuvant setting based on no evidence. But I believe that this worked very well in preoperative setting, and it may have some effect in post-operative setting as well.
Okay. Okay.
I would
But
go
observation
with
is not wrong.
observation.
Okay.
I do that as well.
Yes. So I think we have this discussion also, Nidal, Kan'an, and Ahmed in the tumor board. And we thought that there is no data to guide what we should do in this patient. However, we thought that just observing this patient for the time being is a reasonable option. And immunotherapy is still a choice for this patient if in case he developed any recurrence in the future. So the immunotherapy used in patient with metastatic with patient with colorectal cancer, it's not something new. However, we know that the use as of now in most of the indication, or actually the approved indication, is to use it in the metastatic setting. But I think this approach is moving more and more in the early stages and early tumor or non-metastatic setting. And we already have some studies that has been looking to the role of immunotherapy in this setting. So all of oncologists aware about this study that looked to the dostarlimab in only 12 patients. And as you can see, all patients actually have complete response, which is something remarkable. More recently, another study, phase 2 study, larger number of patients with biomarker analysis that was done during this study as well, where they studied the role of immunotherapy in the neoadjuvant setting. So where the patient will receive Nivo-Ipi for first cycle, then he will receive Nivo for few cycles, 6 weeks duration, then the patient will go for surgery. So there is no radiation, no other treatment except few cycles of immunotherapy. And if you look also, this is a very remarkable thing that we saw in this study. 67% of patients, they achieve pathological complete response. This is something that we don't see actually with chemotherapy, with radiation, even with TNT. However, still people or some of oncologists reluctant to implement this approach, and they don't think we have the long-term follow-up for this data, and it's better to be compared to the standard of care. However, my personal thought, and I know we have a wide range of audience, I think it's always good to have to follow the guidelines and the evidence. However, not all the cases you can apply this concept on. If you look to the neoadjuvant therapy in patients with colorectal cancer, it's been evolving. Now, so if you want to compare the neoadjuvant immunotherapy to standard of care, so what is the standard of care now for patients with colorectal cancer? Should we compare it to long course chemoradiation? Should we compare it to the TNT? Should we compare it now with the new data that came for that the chemotherapy in some rectal cancer is not inferior to chemo radiation? So I don't think there is a very well-established only standard of care that we can compare this. On the other side, you have a biomarker-driven therapy that has been shown, and we know already those patients who respond to immunotherapy, they're going to have long-lasting response to immunotherapy. So for my side, I think it's always important to discuss with the patient that what is the evidence, the available evidence. And this patient specifically, he was very interested in non-operative approach actually, but he was concerned that he will end up by APR. And this is a concern for patients with Lynch syndrome with rectal cancer. So if you operate on a 20 years or 30 years old patient and you give them a permanent stoma for the rest of their life, I think this has a huge impact in their quality of life. And you have a very effective therapy. And I think my personal feeling, there is a very strong evidence of using immunotherapy in the neoadjuvant setting in patients with rectal cancer. So this is just some thought about this case and summary of this patient journey. And I'm happy to discuss any further question or comments.
Excellent case, يا محمد. الله يعطيك العافية. ما شاء الله, very informative cases today. You guys hear me?
Yes.
Yes. Right. Actually, I'm going to start off with the management of locally advanced rectal cancer. I'm curious to know, guys, did you guys fully adopt the rapido approach, short course radiation followed by chemotherapy at your institute? Are colorectal surgeons fully comfortable with the rapido approach, or do some of them dislike it because of post-operative toxicities?
Well, I think...
And this question is directed to Ahmed as well, the guys in National Guard and Ahmed.
Okay.
Okay.
Well, I think, Nidal, as you know, it's a multidisciplinary discussion. Personally, I'm leaning toward more of total neoadjuvant therapy in patients without MSI high disease. I think it's always good to test the biology of the tumor, and at the same time, it's good to obtain some downsizing of the tumor in order to allow also, I would say, smaller field of radiation, or allow big field of radiation to become smaller. I think it's always a good idea to have to use the TNT. However, in certain cases, I think we find that short courses is feasible. It's all dependent on the radiological finding. If you don't have really significant lymphadenopathy, T3 tumor, early T3, sometimes we consider just short course of radiation. So I don't think there is one size that fits all, but I think I'm inclined more of TNT approach for other than MSI high patients.
So, for instance, T4N1 disease, T4N2 disease, you would still do mid or upper, of course. You would still do rapid approach. Okay, beautiful. What about you, Ahmed? What's the common practice at your center?
It's actually TNT nowadays, and it's very convenient for us because we don't have ready available radiation equipments in our hospital. We use the one at the King Abdulaziz University.
صح.
So it gives us some kind of leeway, just short course quickly, and then go ahead with chemotherapy as per the Rapido. However, I mean, when you look at it, it's made the T4 N2s, or the N2s basically has been recommended in the Rapido approach. So we actually had been adapting that kind of approach more prominently. In some selected cases, we go ahead with concurrent chemorad, because if we think that they will not be able to tolerate the oxaliplatin part. So it's basically you have to tailor down your approach based on the patient in front of you, but mainly Rapido, TNT.
Beautiful. You guys have any questions to Muhammad or to any of the panelists? Fadal.
I do have a lot of questions to Muhammad, Dr. Muhammad. Dr. Muhammad, that was an excellent case. I think we saved the best case to last. I would really appreciate it if you'd be able to turn on your camera, but I think you're having technical difficulties, Dr. Muhammad. Anyways, can you hear us, Dr. Muhammad Agarni? You're with us. I cannot hear him. Can you guys hear him?
Muhammad muted his microphone.
Sorry, I got an important call. Yes, sorry,
okay,
I missed
so you're with us. Okay.
يقول أحلى كيس اليوم الكيس حقتك.
Yeah, I was saying that. I was saying we saved the best for the last. So Dr. Muhammad, thank you for sharing the excellent case. That was an excellent management of the case as well. Tracking back, should we have the dostarlimab article in the study, basically, and we have the niche 2 study. When you have all the panels, like basically in front of you, all the markers, you know that this patient has MSI high, local advanced rectal cancer. How would you approach such case nowadays? Should you go back in time knowing all that?
So Ahmed, I think if I understand your question correctly, for MSI high patient, should we consider immunotherapy for all patients?
Exactly. Yeah. Would you have given the dostarlimab?
Well, I think once you have a good biomarker, I think all agents work, especially the, we don't have the dostarlimab in our country, but I think you have the niche study combination, which is available in most of the hospitals. So I think all MSI high rectal cancer, locally advanced, non-metastatic, I think they should be treated with immunotherapy. Now the agent is dependent on what's available. I think we should go with the evidence now that we have with Nivo-EP, because we have more number of patients, more I would say more accessibility to the drug. And I think it's a matter of time before we start to manage patients with MSI high with a non-operative approach. This is what I feel is coming, but it's just a matter of time.
Absolutely. And this is exactly what I really wanted to hear, because I had been burnt by that fire at least twice. 2 cases of MSI high. I knew about them being MSI high before we go down the route of TNT, and 2 of them did very poorly with the TNT approach. Neither radiation helped nor concurrent chemorad helped. Not even the chemotherapy did not even touch them until I started the pembrolizumab. After surgery, they had a flourished metastatic disease, and pembrolizumab had controlled the disease for now 4 years. 4 years. This is the thing. Should I had known before that, and there's a commitment to myself, I would have started immunotherapy right away. I would not even think twice. No TNT for those patients. It's only immunotherapy. So I know the skepticism, and I know all those kind of basically the end markers and the endpoints that we have to look at in terms of the overall survival, the PFS, DFS, and all that stuff. Basically, when the dostarlimab evidence came about. But I think, as you stated, MSI high patients, locally advanced immunotherapy is the way to go, basically for them. The choice is going to be a bit different, but it all depends on what you have in your institution. So
Ahmed, sorry to interrupt, but I have a completely different experience with MSI high patients with local advanced rectal cancer actually responding on chemotherapy. I have a guy in his mid-50s. This was prior to the dostarlimab study. I started him on TNT. طبعا he was symptomatic, يعني big tumor, bleeding. I started him. صراحة he responded clinically. Radiologically, he responded. And then a smart pathologist decided to send for MSI, يعني without really يمكن reporting the result back to us. So during my review of the patient, I went back and looked at the pathology. I'm not sure why. And I found that he was, the MSI was sent later, and he came about to be being microsatellite unstable. But he had evidence of radiological and clinical response. We were in mid of TNT. So I asked the majority of my colleagues, and some of them had different answers, but I decided to continue TNT since he was clinically and radiologically responding. He had, بعد ما خلصنا, he had actually concurrent chemo radio. بعدها he had surgery, and he had a good pathological response, not near ولا complete, but a good pathological response, and he's been disease-free since. Probably going back in time, if I had known that he was microsatellite unstable from the beginning, still I wouldn't be really sure with a large bleeding rectal cancer. And I still think we have a lot of unanswered questions. And if you want a quick response, I'd probably depend, probably more on chemotherapy rather than immunotherapy. That's my short comment. But my question to everyone is, what does everyone think about non-operative management? Following the Dostarlimab study with clinical responses, would you, Muhammad, Nidal, Ahmed, someone is responding clinically well, you think that he is clinically and radiologically in CR. Non-lynch. Lynch is a different story. You need to do your total colectomy. Non-lynch, would you actually push for, وإذا كانت surgery non-APR, ما راح يكون عنده permanent stoma, would you push for surgery or not? I'm very interested to know what everyone is thinking. So I'll probably start with you, Nidal.
So, to be honest with you, psychologically, we are still doing surgery at my center. Very few cases, as you know very well, probably less than 5% a year, will end up having complete responses at my institute. And we end up doing surgery for everybody. Keeping in mind that Haber-Gamma series showed good results with watchful waiting, but we're not doing it. We are doing surgery, and sometimes we're giving adjuvant chemotherapy based on the pre-radiation, concurrent chemoradiation staging. بالأمانة, we're doing everything.
Yeah, I would do the same. طبعا أول شيء very short comment. ترى كل ال PCRs عندنا ماسكهم محمد القرني ما شاء الله.
ما شاء الله تبارك.
Are with him. But if would I apply OPRA with the follow-up with their follow-up regimen actually of clinical responders? I probably wouldn't. I don't think patients in our population would actually follow up their very aggressive surveillance regimen. I would feel strongly towards surgery. I'm not sure, Ahmed or Muhammad, what do you guys think?
I think the problem with non-operative approach, it's an appealing approach, but the problem is, first, how do you define complete, pathological response, and how you would establish a very good, let's say, surveillance for those patients. The problem is very intensive follow-up, very frequent colonoscopy, very frequent MRIs. And I think it's really challenging as of now to implement a non-operative approach. And sometimes I feel more safe if the patient goes for surgery, to be honest with you, especially for patients that I know that compliance is going to be an issue. So I think still surgery plays a major role, but once we reach to the situation, we identify the people who we can follow with surveillance and know what surveillance that we could do for those patients. I think surgery still plays a major part.
I think this is an excellent question, and we're going to be going now in a virgin territory that no one has ever explored. It is basically something new, and we're quite excited about. I don't think anyone knows the right or wrong answer here. That being said, we have a lot of difficulties in our population with their compliance to hospital and colonoscopies and what have you. And I think we have to tailor down our approach to each patient's basically unique characteristics and whatever their hopes of the outcome is going to be. We all know about the disfiguring operation that most of these patients would go, which is APR ending up with an ostomy bag, unfortunately. So it all depends on the age, comorbidities, and it depends on what the patient's wishes are. I wouldn't mind the watchful waiting approach. It has been proven, it has been shown basically that it is an effective way in selected patients, not in all comers. And it is at the end is a discussion, but that should not persuade us from the standard of care, which is surgery, basically, for these patients.
Thank you, Ahmed.
Thank you.
Excellent cases. Wallahi, I personally learned a lot from the 3 cases. Beautiful responses. Thanks a lot for the invitation, and inshallah we'll see you soon, inshallah, bidnillah ta'ala. Hopefully this weekend.
Inshallah. Thank you.
Thank you, Dr. Nidal, Dr. Ahmed, Dr. Mohammed. The mic is yours to close.
طيب, thank you very much all, and thank you for our virtual attendees for being with us. It was really good cases and good discussion, and looking to see you tomorrow, inshallah, in our day 2 of this activity. And also I would like to thank our supporting technical team, and as well our sponsor for this activity, and see you tomorrow, inshallah. Assalamu alaikum.